हाँ हाँ, अभी डॉक्टर को निपटा के आ रहा हूँ पार्टी के लिए। क्या मैं रोज आइसक्रीम खा सकता हूँ?
When the sugars are decent, why should they face severe amount of sequelae or complications?
The genes that have changed as a result of maybe stress or chemical exposures
Where they claim that if you do this surgery, your diabetes gets reversed.
to restrict the carbohydrates and to augment the physical activity. And many such propaganda programs can actually land you up in a disaster also.
Okay.
I mean, 7-8 years ago, we did not have any good medication for diabetics to reduce weight. Then there came one, and that's why I always tell the importance of Garbha Sanskar, that okay, if there is a family history of diabetes, the mother should start taking care during pregnancy so that the child doesn't develop, or basically the bad genes don't get a chance to express themselves on day one.
So, what is your take on goiter?
Any swelling in the thyroid is goiter.
One of the problems that I'm very commonly seeing is bone mineral density problems.
The BMI, or if you say the body composition, it's more of fat and less of bones. So that makes us more vulnerable to osteoporosis even at a younger age.
When they did cadaveric studies of dead bodies, or when they screened the whole population with ultrasound or sonography, they found that 76% people can have nodules in their necks.
And thyroid surgeries do have a small but genuine risk of voice loss. People have reservation about taking one tablet here, at least 4 tablets a day get added. Similarly, the standard of care is surgery. But now I have a therapy that is available that is less disfiguring, less morbid as compared to surgery, and giving the similar result at a cost of much lesser complications. A hip fracture has the same outcome as a heart attack. Why most of the thyroid problem occurs is your own body destroys your own thyroid gland. What made your body destroy that?
And second, lack of sunlight.
You should have sun to take vitamin D. Which sun? Most of the people think morning sun. That's not true. We have a specific term called a zenith angle, and that defines that which area in the world people should have a typical sun exposure of a UVB rays. So for India, it is between.
As we promised you in one of our videos, when we touch 1 lakh subscribers, we would be starting a medical podcast channel where we will not only talk about interventional radiology procedures, but about each and every subspecialty with special super specialty guest doctors who will talk about their branch and what they have to offer to their patients, so that we help each one of you getting more aware and more empowered about different diseases, not only problems that I can solve as an interventional radiologist. So today I am very honored that the first guest which we have is Dr. Ameya Joshi. I always knew that when I'll start, he will be our first guest, and I am privileged and honored that he accepted our request very gracefully and gave us a lot of time. Dr. Ameya Joshi is an endocrine specialist, a person who deals with hormonal disorders, which can range from diabetes to thyroid problems, from bone mineral problems to sexual health, and a lot more. Through this podcast, you will learn about all these diseases and their treatments, so stay tuned. But just introducing the speaker a bit, Dr. Ameya did his MBBS from the prestigious Grant Medical College. Then he did his post-graduation and super specialty in endocrinology from the prestigious Topiwala National Medical College and BYL Nayar Charitable Hospital. For those who know India, it is a prestigious government university in Mumbai. Of course, during his super specialty in endocrinology, he was a university topper, and his academic achievement started right from that young age and training time. After that, he has so many accreditations and training programs in advanced diabetology and other diseases from Leuven, from Belgium. He's even accredited into pediatric endocrinology from ISPAE Society. So the list of his academic achievements, his patient treatment volumes, and his research achievements are unlimited. I can't even go into the volumes that he is contributing to. But I can tell you that he specializes into a lot of these endocrine disorders and their management. The main areas that he focuses on are diabetes, obesity management, thyroid disorders management, reproductive endocrinology, that is reproductive issues in young age as well as pediatric age, and endocrinological tumors. So if you have any of these diseases, or even if you don't, you want to learn about preventive endocrinology, that means how to stay away from thyroid, from diabetes, obesity, and such problems, then this is a podcast that you should be looking for. Stay tuned, stay empowered. So, greetings, sir. Welcome to our podcast. I am very happy to be the host where we can invite you as our first guest for our audience to learn so much on these important topics that you cater to. So, without wasting any time, I would want the audience, because there is so much to learn on these topics and there are so many queries. So, let's just straight delve in.
Yeah, let me express my gratitude also for having me here on this wonderful morning, and it's always a pleasure to be with you.
Thank you, sir. So, sir, I would directly start with a very important question that I see there is a lot of buzz on social media about. Everywhere now we see ads and we even see organic videos talking about diabetes reversal, where so many platforms, tech startups, even AI based platforms are coming and claiming that diabetes is completely curable and reversible. And we don't see any details about it, because only once you enroll in the program can you understand what is the algorithm or the process, how they do it. But as an endocrinologist, what is your take on this? Is this something new that medical science or these platforms have discovered, and or are endocrinologists following this from earlier times? And is it even possible? Because as far as we know, conventionally as medical students, what we have been taught is once the beta cells pancreas are destroyed, diabetes is a chronic lifelong disease. So this is new even for us doctors. So for our patients, diabetic community, for our doctors, what is your take as an endocrinologist? Are these platforms true, or are they over exaggerating something which may be transient? So we would like to know from you. This is a very important topic. So what's your take on this?
I think there are so many startups, as you say. I think every day or week, even somebody from them will come to meet us in the clinic and say that they want to take up some patients or maybe some people with diabetes, if you have to word that ways, for their own program. So I must tell you that this is not exactly new. In fact, in a very interesting way, uh, the first time when reversal was used for diabetes, it was in a subgroup of people with diabetes who were diagnosed with very high glucose levels and were given insulin. And within few weeks, they realized that now they no longer need insulin and the glucose levels are maintained without any medication.
Okay.
Exactly because insulin gave rest to their pancreas. But was insulin a sellable idea? If you tell 10 of your patients, okay, please start insulin and you may not need it, first is they won't believe and they won't be ready to accept. But the bottom line here was you gave rest to the pancreas. Then another group of people were identified where those who did very well. So the advice was the same: restrict the carbohydrates and augment your physical activity. There could be different patterns which many propaganda teams do. But then these group of people also managed to stop the medications after they reduced around 8 to 10% of their body weight.
Okay.
And then when this struck few brilliant brains, they came up with different ways or structures with the same principle to restrict the carbohydrates and to augment the physical activity. Now that works. But in whom does it work? The first thing that anybody who wants to reverse his or her diabetes should keep in mind is that they should have a diagnosis. And the diagnosis should be of type 2 diabetes. So obviously there are other types of diabetes which an expert can tell you. So the diabetes should be a type 2 diabetes beyond doubt. And usually the outcomes of reversal are best seen in those who are within first 5 to 7 years of their diabetes diagnosis. And then I'll try to put in three important things which anybody who wants to join a reversal program, and yes, obviously I don't take a guarantee of all of them because some are scientific, some are propaganda and have their own group of what I can say successful examples promoting it. The first thing is the person should accept. The A stands for acceptance of the state of diabetes. So many times people say, that doctor, I will join this reversal program and see in 3 months I'll be eating mangoes. The scene is, the mango season is around the corner. So the reversal is not like that. You have to accept the teachings of a good reversal program. And a good reversal program teaching is, as I said, you have to restrict the carbohydrates, at times even give up on your meals. So the most successful way of doing that is replace your meals with meal replacers, which is a concept well accepted in the West, but in our psyche it is not yet well accepted. So we have to accept the disease, you have to accept the basically teachings of the reversal program. The second is going to be obviously B, and the B stands for behavioral change. So you have to change your behavior accordingly. You have to tune your mind to totally adapt that, okay, this is the health promoting behavior that I am going to stick to. The longer I stick to it, the longer I remain reversed. Because there was another term, remission. And that means that it's gone.
Right.
So the science said that let us not use remission. Let us use reversal. Because it can reverse other way around also. And all people who join reversal should remember that if their behavioral change is not adapted to, there will be a reversal in the other way also. And the hyperglycemia can come back. And then comes the third way that all people should remember, and that is the C. The C stands for consistency. Consistency in maintaining the A of acceptance and B of behavioral change. Obviously, it will need a monitoring, it will need regular screening of complications, and remember that when you join a reversal program, you are adapting to a life where your calorie requirement has came down and you have committed yourself to an augmented physical activity. The moment you lapse, and even if you lapse by 20 to 30%, your metabolism will go back to the deranged state again, and it might go back faster. But yes, diabetes reversal is true. It is accepted by science. There are a lot of startups. Some of them are really doing a good work. But it is important that you join these programs after a proper medical consultation, supervision, and if the try to always see that whether the program is scientifically validated, which obviously you can get a confirmation from your doctor, or there are professional bodies which validate reversal programs, because there are many, I must say that every good thing is surrounded by many suspicious things which try to capitalize on the virtue of that good thing. And many such propaganda programs can actually land you up in a disaster also. So yes, a good diabetes reversal program has been done. In Western countries, it has been done even on a national level. Even there had been an Indian diabetes prevention program. However, it has to be done in a validated manner under a qualified professional, and obviously following the ABC.
Thank you for sharing the difference between remission and reversal. So we understand that it can be transient, especially if the person defaults and does not follow the ABCs. So thank you for that. Now, sir, this was one thing which was bugging us and a lot of patients of ours. And from long time, there was this information. So a lot of clarity has been shed on that. But the second, I would say, propaganda or maybe information, we'll know after your answer, is that there are a lot of surgeries coming up now where they claim that if you do this surgery, your diabetes gets reversed. So I recently saw a paper clip where they said so-and-so corporate hospital did a surgery, a bariatric surgery, and the patient's diabetes improved. So is the surgery a fact? And who is a proper candidate for that? So even a type 2 diabetic who is not obese, can he undergo such a kind of a surgery, a bariatric type of surgery or a bypass surgery where the pancreas gets rest because of the surgery and diabetes be reversed? Or again, even through that, there is a big substrata and big insight and thought as to which patients would be the best candidates. So what is your take on the surgery aspect?
Let me begin an answer to this from our first question or connecting to it. So what diabetes reversal programs do is to offer you a weight loss of 8 to 10%, and you reverse the diabetes. However, what bariatric surgery does is offers you a weight loss of typically 30 to 50%. You can imagine a weight loss of 30 to 50% and the magnitude of impact on that. The bariatric surgeries further increase a hormone in the body called as incretin, which suppresses the appetite and in a way helps in diabetes reversal. Basically, bariatric surgery is a surgical way of diabetes reversal. We first talk about a lifestyle way of diabetes reversal. Bariatric surgery is a surgical way of diabetes reversal. And in deserved candidates. Now, who are those deserved candidates? Those with a body mass index above 40 or those with a body mass index above 35 who have significant comorbidities that prevent them from joining a reversal program, like somebody who has a physical limitation, so cannot augment physical activity. Definitely for them, bariatric surgery is a good option. The reversal rates with bariatric surgery are as high as 30 to 50%, at times even more, as quoted for reversal of, again, underline, type 2 diabetes. Type 1 or insulin dependent diabetes doesn't reverse with bariatric surgery. And yes, those who fall in this category, for them, it's a good option. Now comes two more things. Can this option be used by people with a lesser body mass index? I think it has been looked at in some articles and they did give you a promising result. But let me flag out one thing over here. When you hear something and hear something from a protagonist, the only positives are put forward. Both of us are basically, you can say, followers or disciples of Srimad Bhagavad Gita, and we always believe in a decision on equipoise. And the equipoise demands that you discuss the complications of bariatric surgery, the dumping syndromes, the hypoglycemias that can occur in a reactive manner, the surgical complications, the nutritional deficiencies, the loss of bone density. The life gets committed to a different, what I can say, medical condition post bariatric surgery. And if you start having hypoglycemias post bariatric surgery, it's a hell out of it. You have basically made your life more miserable than what it could have been pre-surgery with a medically managed disease. And those with a BMI below 35 can actually reduce their weight by 8 to 10% by simple diabetes reversal programs. And that gives them the same outcome without all these complications, So they don't stand out as the right candidates for the surgical intervention. And then let me put the third way around. And that's what I told you, that there is one way and then there is another way also. And that is medical weight loss. I mean, 7-8 years ago, we did not have any good medication for diabetics to reduce weight. Then there came one medication called as SGLT2 inhibitor that caused urinary glucose loss. But now we have a group of medications called as GLP-1 receptor agonists. And what do? They are basically the same incretin hormone that is increased by bariatric surgery to reverse diabetes. Now, when the cream of the bariatric surgery advantage is available as a medicine, everybody will want to opt for that. And now we have mixed incretin analogs, which actually have delivered 20 to 25% weight loss, which is almost 80% of what your bariatric surgery will achieve. You are getting 30 to 50% there. Here you are getting 25%. Add a little of lifestyle modification and achieve it medically. So the future is quite exciting. Maybe 3-4 years down the line. Currently, these molecules are available in the West. I'm hoping that in a year they should be available to us. And there we can actually see these people who have medically achieved a sustainable weight loss, because post bariatric surgery, few years down the line, you can again start gaining weight because your biology has not changed. I mean, everything else except for that surgical loop and incretin enhanced remains the same. But then if you continue these medications, and they are now being given even to people post bariatric regain, then why not take it from day one rather than surgery? So, I mean, the therapeutic options and future options that are available for people with diabetes, particularly obese people with diabetes, are exciting. And we are looking at a time where, yes, we have a mounting problem, but we have an exciting array of solutions.
Wow, wonderful. This was one of the most insightful light shed or clarity shed on this topic, which was, I would say, clouded and very confusing for most of us, including doctors, not only patients. So good, we now know a lot about it, and especially learning about this medical management and with combined with behavioral change, how maybe potentially we can avoid a lot of bariatric surgeries in so many patients. Wonderful, sir. Now, sir, as an interventional radiologist, the next question is very close to me. I get so many patients of diabetic foot or gangrene where these patient comes with blackening of toes or certain areas in the legs because of lack of oxygen supply or blood supply. We also get patients with rest pain or claudication where even if they walk a few steps, they start having severe pain and they have to wait. When we evaluate, we find that there are a lot of blockages in the blood vessels of their legs, just like blockages occur in the heart, cause heart attacks. So cardiologists also get a lot of patients of diabetes, but because I'm an intervention radiologist dealing with the rest of the body, I get these patients having gangrene and other sequelae. So many of these patients, I would say, some of these patients are a substrata where they honestly accept that their sugars have never been controlled. So there I accept that such sequelae can occur because of uncontrolled sugars over a period of decades. But so many patients, they show us their charts and they say, Dr. Saab, these our sugar levels were always normal. Our fasting, postprandial with our medication or insulin, they are pretty decent. So when the sugars are decent, why should they face severe amount of sequelae or complications? In fact, when we finally take few of them for angiography or angioplasty, we find that the creatinine levels are also not normal, because of which we are restricted. We cannot use our dye for the angiography. That might harm the kidney more to in some selected patients. So why such amount of damage to the kidney, sometimes to the eyes? We hear about retinopathies, even to the blood vessels, causing gangrene or heart attacks or strokes in these patients. What is going wrong in their management overall over the long period of their diabetes? And what can be done to prevent these complications? How can a diabetes patient be normal throughout, not worrying about having their kidneys failed or having these blockages with these kind of issues? So what is going wrong and what can be done to correct it? So,
Question of so many of our patients, But let us try to look at maybe both of us. And we stand quite tall. Have you thought about it? Almost touching 6 feet. So have we ever asked why we are so tall? I mean, being tall and being short are also results of some biological equation somewhere, no?
Right.
And that's because our parents gave us that height to a great extent. Height is a function of your parents gave you.
Right.
Similarly, that's our destiny. Similarly, a good chunk of diseases, and I would here put it on record that many a times we criminalize people. Okay, you are eating more, so you have got diabetes. You are not doing this, you are not doing this. And in fact, the person sitting in front of you may actually have done everything right. Right from getting diagnosed early, right from following a diet that was given, right from being physically active, right from being monitoring things properly. And that part is actually the destiny, the set of genes that the person has inherited, or the genes that have changed as a result of maybe stress or infections or chemical exposures. And let me put these three modulators on the record for all our audience, that one part is destiny, the second part is these three. It's coming up in a big way, and mind, body, and medicine are connected. We all know that, and we seldom acknowledge the presence of mind as a causative agent of diseases, and that's the stress part of it. Nobody has escaped that, in current world, not even you and me. The second is what we call it as epigenetic changes, the changes that are driven by the infections that we face. We saw so many people getting a myocardial infarction during COVID, young people. So basically the trigger was there. And then viral infections do trigger inflammation and all of that. And then the third is the chemical exposure. I mean, in good old days, the chemical exposures was less. Now it has increased by leaps and bounds. We are staying in Mumbai, we can't accept. I mean, the life expectancy in Mumbai is 10 years less than what rest of India has. That's the indirect proof of this. No? So that also modifies your genes. So that is about the epigenetic and genetic risk. Obviously, this doesn't mean that you should give up exercise, you should give up carb restriction, and okay, it's my destiny, so let me face my destiny. It doesn't look like that. You can still, so I will tell you maybe an example. A 60-year-old or a 50-year-old gentleman coming with a myocardial infarction who was diagnosed diabetic at the age of 30 years. Say 30, and then did everything right, and is having an MI at 50. And there, obviously, if you inquire, there will be a family history of people getting an early heart attack, people getting early diabetes, genetic predisposition. But had that person not had an early diagnosis and an early monitoring or maybe early interventions, lifestyle and diet and monitoring and medical basically, he or she could have got the same fate a decade earlier. So that's the strength of prolonging the complications that your destiny has given you. And that's why I always tell the importance of Garbha Sanskar, that okay, if there is a family history of diabetes, the mother should start taking care during pregnancy so that the child doesn't develop, or basically the bad genes don't get a chance to express themselves on day one. The longer you can prolong it, the longer you are having a successful life. So one is acknowledging the genetic and the non-modifiable risk factors. We typically had in our paper, no, while we write an answer, modifiable and non-modifiable. So non-modifiable will remain. Our modifiable part, what medical interventions we offer, as well as the lifestyle changes, will basically help us delay the inevitable. Obviously, the inevitable is true for everyone. So that's the reason why a good number, and we did a screening program for our type 2 diabetics. So the third is whether I can do anything for it. And that is how the thing of early diagnosis and treating early comes. So if you get an early diagnosis, definitely you can take a corrective step early, even if it means a medical intervention or a surgical intervention, but can prevent deterioration in a quality of life. Remember, a person we spoke about, say 50-year-old person, getting a myocardial infarction and succumbing to it, or he being getting diagnosed at 49 with a ischemic heart disease, going a proactive intervention. So he underwent a treatment of a possible myocardial infarction and then living for 80 years is again a success. And that's why is an equilibrium about what I can say mind, the body, and the what I can say medical science, if not medicine, medical science part of it, which can be sort of adjusted in a way that you prolong the inevitable for a longer time.
Very interesting, sir. So I'll just share an anecdote history in my family and something amazing out of it, and then hear your take on it. So my grandfather, he had diabetes, and whenever we went to a doctor, he used to show his fasting and postprandial a day prior, and that used to be bang normal. And my grandfather would say, "Look, doctor, I'm doing everything right." And the doctor, again, an endocrinologist, that is where I learned the importance of an endocrinologist, because I see so many diabetes specialists, someone who has done a fellowship, a 3-month fellowship, but then I felt a difference when an endocrinologist treats you. So the endocrinologist said that, look, I understand your fasting and postprandial is good, but let me do a test known as HbA1c. That is the first time, I was not even a medical student then, where I learned about this test, where he said he will test your average sugar for the last 3 months. And when he did that, to our shock, he said your HbA1c is 9.5, which is much more than the normal 6. That means your sugars are completely uncontrolled from the past 3 months. And we asked him that one day before the fasting, the post-meal sugars are all bang normal. So how can the 3-month average sugar be bad? He said your grandfather is cheating you. He is not controlling his sugars for the full 3 months. Just on the before the day of test, he does a good amount of fasting. He does all the things right, and that's why that one test comes normal. So he skips his sugars, he skips his meals also, just to be looking good in front of the doctor and also not getting chastisement from family. And when we actually confronted him, we came to know that he cheats many of the nights when we sleep and he eats sugars, skipping into the kitchen. So, what is the importance of this test HbA1c and how frequently should one do it? And do you think that will change the way a diabetic looks at his health and possible problems that can come up compared to doing a fasting and a post meal sugar?
So I'll just tell you two things. I mean, on a lighter note,
Yes, sir.
this Diwali, there was a typical businessman who came to see me, and unfortunately for him, after we finished our consultancy, he was just leaving my cabin and a call came, and he just said, हाँ हाँ अभी डॉक्टर को निपटा के आ रहा हूँ पार्टी के लिए. I mean, that's how things work, you know.
Yeah.
Normal report, a satisfied doctor and a satisfied patient. See, ultimately, it's always between you and your God. It was never between you and your doctor.
Right.
To an extent, doctor is just a modifier of your good life or a good quality of
Yeah.
life. Nature is a very hard teacher, and that's what I always tell my patients that okay, you're not getting a result out of me, you know. What you are telling me, okay, क्या मैं रोज आइसक्रीम खा सकता हूँ? As if I give you a permission and you eat ice cream daily, your glucose level will never go up. It's bound to go up because nature is going to give you that result. That's nature's destiny for you. And there comes the importance of another important metrics of diabetes, and that is time. Many times we say that, okay, my glucose level has always been normal, but you have been in that pathophysiological state of insulin resistance and inflammation, which is damaging your body beyond the glucose control. And so 20 years diabetic, meaning 20 years these two things have sort of played their evil in your body. So the complications are also a function of time. And then there comes the HbA1c, the fasting, the PP. The HbA1c is just a matrix in time. Last 3 months, what has happened? And sometimes you even get a normal HbA1c and the patient is not happy because he or she had seen a glucose of 300 and 30 both and taking insulin. And that is what is an HbA1c, which is 7. But at one end it was high glucose, at another end it was low glucose, and the third is a normal result. And there comes the importance of measuring something called as glycemic variability, which we offer to quite a few of our patients nowadays, particularly those who are vulnerable to get low glucose, is to put a chip called as continuous glucose monitor, which shows them what their glucose is in their phone. So they can even make out. And we all know that everybody is different. And this gives us an opportunity to even finalize what that person's biology adapts to. Like some have a high glucose with chapati, some have a high glucose with rice. So obviously if that person knows that 15 days I have written my diet, 15 days this is how my glucose behaved, this is how I took my medication, these were my stress levels. End of the day, a good 15-minute study of that whole thing can help a doctor, a medical professional, a lifestyle modifier, and that person come up with a wonderful personalized plan for that particular person. And that is where we are all heading to, personalized medicine.
So this is very interesting, this continuous glucose monitoring that you brought up. You think this can become the norm, or is it already become the norm in the Western world, and do you think India can adapt? Because it's amazing to have a chip in your arm and just know your sugars after every meal. I remember I was seeing a podcast of one of famous YouTubers, and he said, whenever I ate ice cream, I saw that my sugar peaked up. But I tried some variations and I ate salad before I ate ice cream. And that time the sugars didn't peak up. So maybe the fiber made a difference So even if he said, even if you want to cheat, have some good amount of fiber and then occasionally you can. So do you think that CGM's, continuous glucose monitoring, can become one of the standards of patient monitoring for diabetics?
See, every principle or everything that came up, first came up in a limited quantity, then in an unlimited quantity. Obviously, the dream will always be that every diabetic person should be mindful of his or her sugars all the time.
Right.
But that's a dream, the dream that can be fulfilled by an unlimited resource. So currently, when CGM first came, decade or two ago, I don't remember the exact date, but it came in a very limited number of chips available at a prime price, and the readers used to read it after 15 days. So we used it only in people who are vulnerable. That means those who can be immediately affected by a low glucose.
Okay.
Then we got more number of chips. Now we offer it to anyone who can have little low glucose or where your HbA1c and your glucose levels don't match. And now they are being available in more and more quantity. Now the supply is there. The restriction is price.
Okay.
Obviously, it depends on how much. See, ultimately, what I as a doctor will always want is that the person's glucose level should be round the clock under control. But my first choice will be to implement a measure to do that, and that's lifestyle and medication. And obviously, to continue monitoring will be the another icing on the cake.
Right.
Currently, it's a little far dream, but a dream that seems to be visible with maybe these chips getting economized. I am sure some good make in India startups will also come up, and maybe it's a dream that every diabetic person, like he has or she has a facility to check time, has also a real time glucose coming up, and that helps. Why not, provided we have a resource available at a price which doesn't burden a person's pocket.
Good. I think many of our viewers watching, if some of them are potential entrepreneurs, someone gets the hint of this and we very soon see a Shark Tank funding proposal for a Indian startup making CGMs and may help our country in a big way. So, sir, very insightful discussion on diabetics. Of course, we covered mainly type 2 diabetes in this because we don't want to confuse our viewers with adding a lot of other spectrum like type 1 or other variants. But yes, because getting your time is actually a privilege and a luxury for us. So we will want many of our viewers who have thyroid nodules, other stuff, bone mineral issues, which an endocrinologist can treat and share various perspectives on. We would like to know on that also. So we'll now switch our gears and shift to something about thyroids. So sir, thank you for all the insights on diabetes. Now, as we said, switching gears over to a very common disease about thyroid. I don't want to talk much about hypothyroidism today. Like diabetes, even that's a chronic ailment which I get so many messages for on my channel, whether it's curable, whether it's reversible without any medication. So that's there, and that can be discussed maybe on some other day. Today I want to discuss a very important topic, and since I've started my channel, Dr. Gangwani's Vascular Clinic, this is one of the most sought after topics where lakhs of patients are approaching us from different parts of the country as well as the world, and that's thyroid nodules, or commonly known as goiter. So when I got so many queries, I never thought when I started a wellness program that this is the amount of the number of patients that may be suffering from these lumps. So I realized on my study that when they did cadaveric studies of dead bodies, or when they screened the whole population with ultrasound or sonography, they found that 76% people can have nodules in their necks, in the thyroids. Many of them may be small or occult and not manifest ever as lumps, but in a decent population size, it does manifest as lumps, because of which somebody comments that, oh, I can see some lump in your neck, and then the patient comes to you and you diagnose that it's a goiter or it's a nodule. So what is your take on goiter? What is goiter first, and what do you think is the proportion, and who needs treatment, who doesn't?
So I think any swelling in the thyroid is goiter. It can just be that the whole thyroid gland is enlarged. We call it as a diffuse goiter, which happens in hypothyroidism. And hypothyroidism is a common problem. 15% of the population has it. So a good number will have a diffusely enlarged gland. However, the nodules that we were talking about is a discrete swelling. So whole thyroid, there is one small nodule or multiple nodules, small, big, or whatever. Now, if you look at everyone, let it be me, let it be you, we don't have that typical til or a massa or a swelling. That's also a kind of nodule or a swelling. Now, we don't panic about it, but we know that it's there. Similarly, what has happened, and we spoke about resource. Let us connect the resource over it. So as the resource of getting an ultrasound became more and more available, both in terms of the machine availability and a good qualified trained person being available to do that, we started diagnosing. So anything that was nodule, as you said, everybody will have a nodule somewhere or the other, say liver or thyroid or the breast, and we started diagnosing these nodules, and some of them even had aberrant cells which could be labeled as cancerous or potentially cancerous. And then we got these statistics that 40 to 70 to 80% of people can have thyroid nodule, of which 10 to 20% can be cancerous. So do we recommend that 20% of the population should be undergoing a removal of their thyroids? And this is a question which was then asked, and then there were actually conferences on that, saying that yes, you can have these nodules, and some of them can be just in situ cancers, but they don't need to be treated, and it can be emotionally traumatizing. Typically of these, nobody will screen everyone, but population screening was done for people from the nuclear bomb survivors of Japan, and that's where these things came up, that at times we could just be over-diagnosing. Now, this doesn't mean that we should ignore them also. There is always a middle way, and the middle way is always shown by a group of experts who revise the literature from time to time. So that middle way can also change, but that is what is the best available resource that we have, given by the brightest minds, and that is called as guidelines. So we have that guidelines. In an ultrasound, so you always report that ultrasound, thyroid score so and so, so I will do a biopsy. Thyroid score so and so, I will not do a biopsy. So that comes to zeroing down the equation further, that 76% have the problem. But out of that, a smaller number actually needs a biopsy. Say, for example, 15% needs a biopsy or FNAC that we do. And then out of that, a proportion are actually diagnosed with a clinically meaningful disease. So let me define a clinically meaningful goiter over here. A clinically emergency goiter is a goiter that is causing a breathing difficulty or a swallowing difficulty, which the person will come and say, "Doctor, whatever it is, please get this out." I though I won't say I don't care. It can be cancerous, not cancerous, but yes, it has to be out, or you just give me a solution for that. The second part of it is those who have a potential goiter, or maybe I would say a tumor, a nodule, which has a ability to grow or spread. Ability to spread is cancer. Ability to grow is even a cancerous or a non-cancerous lesion that has increased in size over a period of time. And then obviously comes the role of cancer. So cancerous swellings, if it is diagnosed, nobody will really want to keep it in situ. Will prefer to get it removed. So yes, goiter is common, but yes, it needs to be attended also. So if anybody comes with a neck swelling that is visible, or even the person can feel, or at times even it has been incidentally diagnosed, you do a sonography for, say, getting some lymph node or for other reason in the neck, or you just do a PET scan and pick up something in the thyroid. So anything that has came to vision needs due medical attention. A careful thrashing out at all levels to rule out a future risk. And if it is identified, needs a treatment.
Nice. So, sir, since you brought out about this emergency medical goiters, and we know so many people know that there is a lump from decades. So we have so many patients who tell us, "Ki sir, this lump is there from the past 11 years, 20 years." And finally they come to us, seeing our awareness program on non-surgical options, where we can treat these nodules with a needle or with angiography. And this is, sir, good. Finally, I found you. So treat this. Now it is causing breathing difficulty, swallowing difficulty. My question is, there are so many diseases for which people don't mind undergoing a surgery. People have gallstones, and we know how rampant is cholecystectomy, gallbladder removal. People have uterus issues, high bleeding, fibroids, and we know that uterus removal, hysterectomy is very common now. But why do people not like to treat their goiters? So many people are carrying these lumps from decades. Some of their lumps have gone into the chest. Some of them are huge. You can see them cosmetically. They have to hide it using mufflers and turtlenecks, but they don't want to get a neck surgery done. What is the difference between any other surgery and neck surgery, and why people are not comfortable getting a neck surgery done or thyroid removal done for that matter?
Yeah. So there comes the role of mind.
Hmm.
And mind always addresses what is bothering. I mean, any lady who has menorrhagia, unwanted bleeding,
Hmm.
will develop low hemoglobin, anemia. At times, even the religious acceptance of getting unwanted bleeding is there. And then the possible risk of cancer, obviously, if there is an endometrial thickening. So, the biology, the mind acceptance, and the possible risk, all of them make hysterectomies a very sort of acceptable procedure. At times, even at a slightest of a hint, say a 50-year-old lady who had a menopause 3 years ago and now had got a bleeding, what will she think? She will think that, can it land up in trouble? Can it make her weak? It's not natural and it has shown. Or can it be a cancer? Obviously, she has to get thoroughly evaluated for a cancer, but at that time, she will also think that, okay, now the function of that organ is not there. So maybe I can be a little liberal in considering the removal or hysterectomy because the problem can recur. The similar thing is there about gallstone. Many a times, so nobody will do a sonography without a concern, They will only do it when there is some trouble, and it might just be an acidity or maybe something that is there in the, just for example, say diabetics do it to look for fatty liver or a kidney health, and they find gallstones and then there are stones. So then whether it is the reason of the trouble, and sometimes even after discussing they realize, and not every gallstone person undergoes a surgery, but those where it is medically indicated, they go ahead with this thought that sometime it will obstruct, and yes, there is a genuine risk of pancreatitis. If it is medically advisable and told by a surgeon, they will agree that later on it might cause a problem. Now here they are seeing something in the neck, and ironically you spoke about the goiter that's extending below. That's even worse, because retrosternal goiter, it may not be visible also. And then people roam around with those swellings in the neck. So then they think that, okay, why am I supposed to get this removed? If it is cancerous, yes, I will. And there is the role of evaluation, that person should be evaluated. And the second thing is the sensitization for follow-up. Okay. I mean, at times we see an FNAC done. Okay, it was non-cancerous. So it's not a cancer, no. Now, 2 years down the line, it's there. It was not cancerous. That person came for diabetes. I said, okay, look, this is there. And has it grown? The person says, sir, it seems it has grown. So there comes the role of a correct medical communication that, okay, you have this can increase. This may or may not be a cancer, but it can also compromise your breathing and swallowing at a later date. And yes, it can be a potential trouble in your body. This doesn't mean that every nodule needs a surgery, but a reasonable number do need a surgery. And the indication for that can not be defined at one point of time. At one point of time, yes, but it also needs a careful follow-up. And now, fortunately, we have you with us who may not always ask the patient to get operated, but offer something that's quite more exciting. And we find more and more patients accepting the what I typically say radiological intervention for management of these nodules.
Wonderful, sir. So I think the one apprehension that people share with us when we talk about a open surgery, so is that they are fearful of the hypothyroidism that can occur, and they feel that when they have a natural thyroid, they'll have to be on medications for life. They fear the calcium medication that they might need to take, because sometimes the parathyroid glands are also manipulated or removed. And voice change is a risk which many people fear, and we know that in good hands the risk is very low in surgeries, but in open surgeries, but even for the 2% risk, people are not ready to accept that, because somehow everyone is very fearful of a voice change maybe. And lastly, what my patient shared with me is they don't want a scar, because they feel that now it's a lump and a cosmetic issue, but then that will go away, but there will be a scar. And especially patients who know their body has a tendency for hypertrophic scars or keloids, they always fear that if that kind of a keloid forms on the neck, then what? So that is the apprehension with which all these patients came to us, and we were pressed upon trying to find out novel or other minimally invasive alternatives. And that's when, as you rightly said, we have started introducing these two techniques. For smaller nodules, we do ablation, we burn them with a needle. For larger nodules, we do angiography and knock off the blood supply, embolization, because of which the larger nodules or the multinodular goiters start shrinking. So, with these technology available, do you think this can, at least for benign non-cancerous nodule, start replacing as a first line standard of care, start replacing surgery and become the first line of the standard of care for treatment in the future? Again, like you said, a dream or a distant vision.
See, as of now, it stands as available treatment,
Hmm.
but the flow remains the same.
Right.
The resource and the qualified personnel.
Hmm.
Remember that while, say, this was described quite a few years ago, it took many years for Dr. Gaurav Gangwani to land and make it available for us in the, what I can say, suburbs of Mumbai. And then the people started opting for it.
Hmm.
The constraint remains the same ways. One is the consumer should be available about it.
Hmm.
So most of the times, if a person goes with a thyroid nodule, non-cancerous, doctor, can I do something for this? The law is all or none. Either you get it operated or accept.
Right.
Now we have this option 3,
Hmm.
that ablate. No scar. The voice, which everybody wants, we are thankful to our voice for the podcast, which nobody wants to lose. And thyroid surgeries do have a small but genuine risk of voice loss. And yes, the gland that's closer to thyroid, called as parathyroid, if that gets damaged, then you are stuck with calcium supplements for life. And nobody will want those. I mean, people have reservation about taking one tablet here, at least 4 tablets a day get added. So nobody will want those things to come up if, even if remotely. So these interventional, non-scarring, I would say, semi-invasive techniques which don't need a hospitalization if, managed well, or if the case is a moderate to low risk, will definitely be more acceptable. Now, I think we discussed about all these things, but we forgot one important thing. Most of our working population is overworked, busy. Even, for example, a housewife has to take care of everyone at home, and a surgery knocks her out for a week, totally non-functional, and next couple of weeks semi-functional. Now with this, she's functional on day 2. Even if you say 1 day of rest, day 3 she's taking care of everything. Nobody will want themselves to be out of action for a longer time, and that is another asset that these techniques carry with them.
So now I'm raising a red flag myself to one of the interventions that I'm streamlining, trying to create awareness on. So the journey which I undertook a few years ago when we started ablations and embolizations in India and especially Mumbai was very interesting. And we created a lot of awareness program on it on our YouTube channel. So now we have lakhs of viewers and people flying in from different countries, different states to get this, to avail this option, because and the results are very promising, both in literature as well as practical experience. But then I came across this podcast from a RFA podcast channel. I think it's a RFA MD channel, a famous growing channel, and they talked about the dangers of being over aggressive with these therapies. So we know from history that whenever a novel therapy is introduced, like the diabetic reversal program we talked about, yes, there are advantages, and many people jump over the idea of having minimally invasive alternatives. But at the same time, we have also seen that over enthusiasm, over eagerness does have its own risks. And history is proof that whenever new interventions are approved, there is a lot of, I would say, over eagerness for it. People say that this is the new thing, this will replace the conventional methods. But over time, when more data ropes in, long term studies rope in, there is more sensibility to it, more there is a better, narrower case selection to it. And then guidelines form, level 1 data creeps in, and we look at it from the proper objective perspective as to where is the place for this intervention in the management of this disease. We have seen it with steroids being used for interstitial lung diseases, for musculoskeletal tendon tears, and then we realize no, they are in the short term very gratifying, in the long term maybe even harmful. So that got replaced with time. So what is your message for patients as well as for intervention radiologists or budding practitioners of these novel interventions who are learning it rampantly, thyroid nodule ablation as well as embolization? Where should we strictly should we follow the guidelines, and how should we be cautious of such kind of mistakes and not be over enthusiastic? So what is the proper place of this intervention?
So as we discussed, every treatment, the place is defined by the available knowledge, evidence, which is analyzed by experts to formulate a guideline.
Right.
Now let us discuss where these ablative interventional therapies currently stand. They stand at a place where they are available at limited places with a limited number of experts, not even all the medical fraternity aware about it. Forget the laymen who are actually having the problem. And then we spoke about different interventions like steroids. So there are some things that we always foresee, So these therapies, they have not yet totally endorsed by guidelines, but definitely mentioned by them as a therapy. I mean, in the sense that at least alluded to, even if with say that needs follow up or whatever way we want to put it. But always there is a, what I can say, one is experience and another is science that defines them. Like with steroid use for treatment of COVID, we knew that glucose levels are going to go up. We knew that infections are going to go up. So that's the knowledge about steroids. Now coming to these particular therapies and thyroid. So these therapies have been in place for much longer time.
Right.
It's that the thyroid centric evidence about them is, I can say, evolving. And with that, we can definitely say that these therapies are reasonably less, what I can say, burdening as compared to the currently available standard of care. So everything gets approved only when it betters the standard of care. If I have a diabetes medicine available at 10 rupees and there is a 100 rupees medication, if I have a 10 rupees medication and if the 100 rupees is going to do the same, why am I going to try that? Similarly, the standard of care is surgery. But now I have a therapy that is available that is less disfiguring, less morbid as compared to surgery and giving the similar result at a cost of much lesser complications. So currently it is a need of an hour that we have more data, but the therapy looks promising. And what I can foresee, I am privileged to have access to you, because that's how you will know what the therapy is exactly doing. And I must say that we have quite a good number of people with these problems who have benefited, and we have not seen the talked about complications. We always try to be cautious by ensuring that whenever a person undergoes the therapy, he or she is euthyroid. If need be, we pre-medicate, post-medicate, be prepared for a little degree of thyroiditis that will occur.
Right.
So whatever precautions, meaning achieving a euthyroidism, achieving a stable fit state, obviously it's a procedure, so the underlying cardiac fitness, underlying lung fitness, underlying overall fitness of the person is taken care of. And then post little thyroiditis, ultimately it's a destructive, but that has not given any morbid outcome to us. All of our patients, thankfully, by grace of God, have done well. So, and as I said, we are privileged to have one of the few teams, thanks to you, that has been doing this work in our country. So I think what we can say from our little limited experience is that it looks a promising therapy which definitely will find a stable concrete place in guidelines in a matter of time to come.
Thank you. Thank you so much, sir, for so many insights on thyroid nodules, goiter, and these emerging therapies and the right perspective of it in the treatment algorithm or protocol. Now, again, thyroid, I recently heard your talk on case series of patients where hypothyroidism was being managed with thyroxine, but it was not working. And you shared multiple case studies. And that was so interesting on how, what is the difference between someone, a doctor treating hypothyroidism versus what an expert can bring into onto the table. So for anyone who has hypothyroidism or thyroid nodules, I always talk about this on my videos. I always propagate or share with patients that they should meet an endocrine specialist, because it does make a difference in the overall management protocol. But yes, since again we shared, having you is a privilege, and we talked about diabetes, we talked about thyroid nodules. We'll shift the gears for a last time, and because one of the problems that I'm very commonly seeing is bone mineral density problems. Yes, everyone knows that old age people get osteoporotic, even small falls can lead to fractures. But now I'm seeing it much more commonly than we used to see earlier in younger to middle age patients. And I recently had a very young colleague, just maybe a few years older than me, who was dancing in a spiritual program, and then he just had a minor jump and he broke his metatarsal in the foot, one of the small bones in the foot. He got it repaired, and this happened a second time. And that is when the doctor said, no, you have some bone mineral density problem. A bone should not break with a small jump. So, and that's when we did a DEXA scan, we came to know he had osteopenia. So this is a very important topic, and more people are facing these bone problems, especially with the introduction of steroids and with so many surgeries of thyroids, parathyroids. This is bariatric surgeries, as we spoke about. This is creeping more and more. So let's jump gears and talk more about it.
Yeah, I think every problem has a destiny. So here the destiny will be if you are born with a low bone mass, and that's pretty rare, you know. The second aspect comes from the deviation from the nature. And in good old days, people used to, I mean, after the school, the child will jump, play. So exercise will come beyond saying. The diet used to be typically devoid of what I can say endocrine disruptors, and there used to be a lot of sun. And so the bone mass used to get built up and up and up. The physical activity, always a young person was beyond doubt thought of as somebody who will be physically very, very active. And so the peak bone mass used to be really good. And we always forget that, you know, the origin of disease as 70 is always, or maybe 50 or maybe 30, is always in has an answer somewhere before. So one of the problems with lack of sun exposure, less proteins in the diet, a carb rich, typically chemical rich diet is again going to be osteoporosis, which comes at an early age. We also need to remember that most of the literature has came from the West, where typically people are tall, stout, and even as a child have a good growth spurt. However, that's lacking in India. We typically are short, little less height as compared to the Caucasian height. The BMI, or if you say the body composition, it's more of fat and less of bones. So that makes us more vulnerable to osteoporosis even at a younger age. But that's again, I would say, a smaller problem. I'm not saying that it's a not important problem, but it's a smaller problem. The bigger challenge is, and I would like to put an analogy here, that when I had to choose a super specialty subject, I thought so many millions of people with diabetes and only 20 seats of endocrinology. Thankfully, there are 200 now. And now you look at millions of people with an increased life expectancy who are there. So the biggest challenge in front of us is to be ready for our senior citizens who are going to increase with their own group of health challenges that they face, who want a better quality of life. But do we have geriatricians? I think a singular number of seats of geriatrics are available. So anybody who wants to pursue a medical career, give geriatrics a very, very good thought. Now, all of them are, I would say, 1/3 of people above 60 have osteoporosis. If you take an example, say 100 people watch this, if they are above 60, 33 will be having osteoporosis. Most of them are unaware because they have not got a bone density done. And further to that, not aware of the impact of the problem. A hip fracture has the same outcome as a heart attack, both in terms of quantity and quality of life. But again, lack of availability of resource, lack of availability of people, and lack of awareness at the consumer level. Even after getting a bone density in a health checkup, okay, I have osteoporosis, I have osteopenia, so what will I do? I'll take calcium. Now, that's not the be all and end all of bone health. I think each one needs to understand that living gracefully is everybody's right, and getting access, getting awareness is important for that. And one of the most important way to do that is to have fit bones and fit muscles. So obviously exercise stays relevant, calcium, vitamin D stays relevant. Your past efforts like going in the sun, exercising, your past life hard work also is there. But also an acknowledgement of the fact that these problems exist and they have medical solutions, which obviously every super specialist can offer. Here an endocrinologist. So millions and millions of people currently, which is going to multiply in a decade to come, and every decade, will have to acknowledge this problem of osteoporosis. And the earlier this awareness goes, I think Indian Society of Bone Mineral Disease is working in that direction. The more number of people get benefited and are able to not only extend their life, but extend a graceful, productive life for a longer time.
Very interesting, sir. So when you were sharing about the one of the major problems of modern day bone mineral issues, two things caught my eye a lot. One is the endocrine disruptors you talk about. So we would like to more about that. Which kind of foods were you referring to, junk foods, or exactly caused that? How these foods, how these chemicals are impacting not only bone health, maybe other endocrine hormone issues also. And second, lack of sunlight, which is very important because everywhere there is construction, and even if someone chooses a particular home based on the sunlight coming at a particular time, within the next year that's off because another society came up there. So we all know that sunlight is something which has become a rare available commodity. So yeah, but some role about this, and what is the solution for these two issues?
Yeah, I think let us go the other way around.
Yeah.
The easier part is the sunlight.
Yeah.
So many times, you should have sun to take vitamin D. Which sun? Most of the people think morning sun. That's not true.
Okay.
We have a specific term called as zenith angle, and that defines that which area in the world people should have a typical sun exposure of a UVB rays. So for India, it is between 10 a.m. to 4 p.m. 15 to 30 minutes of sun exposure of head, face, neck, and arms. That gives you enough vitamin D. So if you are going in the morning sun and then expecting that your vitamin D will be normal, that's not the case.
Oh.
So this is the typical sun exposure that is recommended. And then there is a challenge with us about increased pigmentation in the skin, which again goes with our skin tone. So we may even not get that differentially. So some people will get adequate vitamin D, some people may not. That's subject to their skin tone. So even if you say it is wise to take one vitamin D a month of 60,000 units, that's still a good strategy if you cannot go in the office sun. Like all of us are occupied. If somebody is going in the school from 10 to 5, where is the scope for that? So that's the relevance of, I would say a positive awareness about vitamin D, because it's not a medication, but a way to positive health. It not only strengthens your bones, but also makes your all muscles, including the heart muscles and the brain, more fit. And then coming about endocrine disruptors. So basically everything goes from a gene to the expression of the gene to the final outcome. Let it be secretion of hormones, secretion of enzymes, or many other functions, formation of cells also. Now, anything that modifies the gene, let it be a virus. COVID modifies a lot of gene. The entire population has changed. It was pre-COVID and post-COVID. The viruses, the chemicals, and we abound in them. The plastics that we use, or even the food preservatives and additives. In non-veg food, there are a lot of hormones that they inject, and even in the preserved food. And that's the importance of what we say, okay, so why we don't worry about it? Because it doesn't harm you immediately. So if you have a nice pre-packed burger, the taste is good, the job is done, and you are happy. Or if you have a Coca-Cola, you are very, very, okay, I have fulfilled my thirst, I am happy, nothing went wrong. The thing that goes wrong goes in a matter of months to years. So nobody is immediately bothered about what's happening now. But they change the very expression of your genes. Remember, why most of the thyroid problem occurs is your own body destroys your own thyroid gland. What made your body destroy thyroid gland? Either it was a adaptive nutrition you had, or the wrong chemicals that signaled your body to act against your own thyroid. And similar way, why your cell is now proliferating or growing beyond what it should have done. A simple theory of why cancer occurred. Because either there was a chronic insult to it, like smoking, inflammation finally burst, or these wrong triggers which made the cell signal in such a manner that, okay, it doesn't want to listen to you now, it's proliferating beyond doubt. So that is the disruption that we are calling about, the endocrine disruption, to be specific to my field, and overall what I can say, body disruption that has occurred. So it's the body's abnormal response to the abnormal chemicals that it is facing, and that's the origin of what all chronic diseases.
So it was a super insightful podcast. We covered so many things, from diabetes to thyroid nodules to bone mineral density, and in that due course of conversation we learned so many other aspects also. Before we sign off, sir, a last question for our viewers. I always say that whenever a patient comes to a hospital reception, he says, I have a fracture, or I have pain, I want to consult an orthopedic. I have pain in the left chest, I want to see a cardiologist. So every patient knows whom I have to see if I have a particular problem. But with interventional radiology, that was an issue. No one knew why an interventional radiologist should be approached, or even there is a specialty like this at the reception. So it was always a subspecialty of referral. If a doctor feels that this is something that a vascular expert can deal with, they referred it to us. I feel endocrinology as such, or endocrine specialty, is of course very famous now, but still people know it as someone who treats diabetes or someone who treats thyroids or hypothyroidism. So in general, if someone wants to know what an endocrinologist does and which diseases are supposed to be approached an endocrine specialist for, then what can you just in short tell us about what is an endocrinologist, what are the diseases he or she treats, so that people would know, okay, if I have these issues, then this is the expert who can probably deal with me best. As you said, many super specialists may treat it, including physicians and even family physicians. But yes, and the probably the tertiary level go-to person to go to is an endocrine specialist for this disease. So can you just share?
Yeah, I think that's a very interesting point that you shared. I think we all need based doctors.
Yes.
Earlier, it was only vascular radiologist.
Yeah.
Nobody labeled as a whole interventional pack that who can ablate nodules and all. Similarly, endocrinologists were thyroidologists because there was a need for taking care of thyroid. Then came, diabetologists because diabetes increased by leaps and bounds.
Yes.
But to be, I would say, a non-populist and a scientific definition of an endocrinologist is a doctor who deals with hormones.
Okay.
And all the problems that we are talking about, are the end result of hormonal imbalance. And let's start from childhood. Somebody is tall, somebody is short. We had an analogy of that. So height disorders, growth hormone.
Okay.
Then disorders of puberty, menses coming early, menses coming late, menses not coming or coming in an irregular manner, or child not blooming. So disorders of sexual development and disorders of puberty and menses. Then comes the hormonal aspects of fertility. And then comes the other chronic endocrine disrupted problems, like problem of insulin, diabetes, problem of insulin resistance, obesity, problem of thyroid, hyperthyroidism, problem of adrenal gland, hormone related hypertension, hormone related obesity, hormonal tumors, then problem of testes and ovaries that we discussed about. So also beyond that, some rare problems which are also having a root in their hormones, like hormones of water balance. So that's also something that comes under hormones of calcium and bones and vitamin D. And some people who need hormonal therapies, like people who have gender identity disorders. So the problem is in the brain, but the treatment is hormonal. So it's a branch that has maybe beneficiaries in all homes. So definitely if we look at 20% kids are short and say 40% are obese, and then the similar proportions in the adult population. So it is something that has solutions for everyone, but scientifically, endocrinology is a science of hormones which typically deals with diabetes, thyroid, obesity, osteoporosis, endocrine tumors, adrenal, pituitary problems like acromegaly, Cushing's, the height disorders, the weight disorders, and the disorders of reproductive system.
Wow, that's a big patient population to cater to. So thank you, sir. I mean, we are both as a channel as well as from on behalf of our audience, we are very grateful to you for taking out time from your very busy schedule. So we all know the amount you are contributing to your patients with the amount of time that you give in, and then besides that you have research and academics, you are active everywhere. So with that, giving time for this, for patient education, means a lot to the channel, to the patients, of course. And I'm sure many patients would benefit from this. And we sign off today so that we can allow you to continue your work and your daily schedule. So hope everyone learned from this podcast, and meet you soon for the next episode. Thank you.
Thank you, Dr. Gaurav, for having me here. It was always a privilege to be with you.
Thank you, sir. So if you enjoyed this podcast and learned a lot from it, there is a lot more that is coming up. So don't forget to subscribe and follow and share this with your friends. It may help many.